Hello, everyone, and welcome to this audio podcast. Podcast as part of the Erythropoiesis edition. This audio podcast is part of Hurricane Plexar. This audio podcast is part of Labonix Vendip. This audio podcast is part of a Storm Robotics production. This audio podcast is part of this series. Will sort of will go into the sort of main research the main research aspects in around this series, and applicably subsequently follows on from the audio podcast in this series, in around immunosuppression. So, immunosuppressive therapy or immunosuppression in pediatric renal recipients, or pediatric renal recipients, or pediatric recipients, has been changing, and has been changing as a consequence of the increasing number of immunosuppressive agents, or immunosuppression pharmacotherapeutics. Generic and other new formulation or novel formulations have been emerging onto the market with clinical experience, clinical and where the clinical experiences have been advancing, and it had been expected that clinicians should tailor immunosuppressive protocols or immunosuppression to individual pediatric recipients by optimizing dosages and drugs according to the maturation and clinical stages of recipients. Most information about the clinical pharmacokinetics of immunosuppression or immunosuppressive drugs in pediatric recipients is centered on have been based or centric based have been centric owing according to CSA tacrolimus, FK506, and or MMF, or mycophenolate mofetil, in around renal and liver solid organ transplanted recipients, and data regarding other immunosuppression or immunosuppressants, and transplant types have been limited. Although the clinical pharmacokinetics of these drugs in pediatric renal recipients or transplanted recipients are still to an extent under investigation, owing to where again, as per mentioned, or as aforementioned in previous audio podcasts, as part of this series, the immunosuppression, for example, tacrolimus, and in part or to an extent, cyclosporin, or CSA, where these immunosuppressants or immunosuppression pharmacotherapies are identified, or are identified as primarily being mainstay immunosuppression therapy. Thus immunosuppression immunosuppressants or immunosuppression pharmacotherapy that have been developed through varying clinical trials, for example, sort of subsequently unfortunately do not have or do not have the sort of the sort of potency the potency in sort of in comparison, so to speak, owing to owing to the the uh, the the nature of of tacrolimus and of tacrolimus and cyclosporin in how they they prompt immunosuppressive or immunosuppression in around in around tissue and pathophysiology, um, and so and so. Although the clinical pharmacokinetics of these drugs, of the drugs in pediatric solid organ transplanted recipients are still under investigation, under investigation, it is also at the same time evident that pharmacokinetic parameters observed observed may not be applicable. For example, where clinical trials more often where clinical trials that are carried out in adult recipients may not be applicable to pediatric recipients, especially in younger age groups. And so in general, patients or recipients younger than 5 years old or 5 years of age show higher clearance rates irrespective of the organ transplanted or drug used. At the same time, another important factor that frequently affects clearance, for example, is a recipient's is where this recipient population, or the pediatric recipient population, is the pediatric recipient population and the post-transplant and the post-transplant duration, in accordance with some findings, and in contrast with the usual underdosage in pediatric renal recipients. The need for higher dosages in younger recipients and during the early post-transplant period seems evident. And so, to achieve the best compromise between prevention of acute allograft rejection, or AAR, or rejection, for example, cellular mediated rejection, or CMR, and toxicity, dosage individualization is required, and this may be achieved, or this may be achieved or can be achieved through, again, TDM, or therapeutic drug monitoring. The approach is particularly, again, helpful to ensure the sort of to ensure the sort of cost effectiveness, management of pediatric transplanted recipients, in whom pharmacokinetic behavior, target concentrations for clinical use, and optimal dosage strategies of a particular particular therapeutics may not yet well be, or may not be defined. At the same time, although TDM may be a tool for improving immunosuppressive therapy, there is a little information concerning its positive contribution to clinical events, including outcomes for pediatric recipients. Substantial information to support the use of TDM exists for CSA, and to a lesser to and or had existed TDM had existed sort of more retrospectively for CSA, and sort of to a lesser extent for tacrolimus, but a diversity of options affects implementation in clinical environs. The role of TDM in therapy with mycophenolate mofetil, and sirolimus or rapamycin had yet to be defined. Had yet to be defined regarding both methods, both modalities and clinical indications. Pharmacodynamic monitoring appears more suited to other immunosuppressants. For example, the immunosuppression in the generation around azathioprine and corticosteroids, in the generation around where azathioprine have been sort of fundamental corticosteroids and monoclonal and polyclonal antibodies. If coupled with pharmacokinetic measurements such as monitoring would allow earlier and more precise optimization of therapy. Very few population pharmacokinetic studies or investigations have been carried out in pediatric solid organ transplanted recipients. This type of investigation is required so that techniques such as Bayesian forecasting can be applied to optimize immunosuppression or immunosuppressant pharmacotherapy in pediatric transplanted recipients. Pharmacodynamic monitoring measures biological response to a drug, which alone or coupled with pharmacokinetics provides a novel modality for the optimization of drug dosing. The pharmacodynamic monitoring of CSA and MMF involves measurement of the activity of enzyme calcineurin and inosine monophosphate dehydrogenase accordingly. The pharmacodynamics of AZA or azathioprine is assessed by the measurement, or have been assessed by the measurement of the activity of a transferase referred to as the thiopurine methyl transferase, which is induced by a metabolite of azathioprine, 6-mercaptopurine. The pharmacodynamics of rapamycin or rapamycin or SRL involves the measurement of a P70, P70S6 kinase activities within lymphocytes, whereas that for MMF, involves the measurement of the endogenous synthesis of that, whereas that for MMF involves the measurement of the endogenous synthesis of cortisol by the suppression of the hypothalamic pituitary axis. To date, the most detailed investigations have been performed involving pharmacodynamic monitoring of CSA and MMF. Similarities exist in the pharmacodynamic response to CSA and MMF in recipients who undergo renal transplantation. At trough concentrations in blood, both pharmacotherapies result in around 50% reduction in activity of target enzymes. However, there is a considerable interpatient variability. Throughout the dosing interval, enzyme activity parallels that of drug concentrations. Renal transplanted recipients who are treated with AZA or azathioprine or have been treated with azathioprine and who exhibit an increase in thiopurine methyl transferase activity from the time of transplantation experience fewer episodes of AAR or acute or active rejection. Renal transplanted recipients who are administered uh, who are im- who are administered mycophenolate, and in whom a suppression of endogenous synthesis of cortisol is greatest exhibit is the least incidence of steroid induced side effects. Additional clinical trials relating or regarding pharmacokinetics and pharmacodynamic parameters to clinical response had been underway to ascertain which provides the best guide for dosing. The pharmacokinetics of tacrolimus have been studied in healthy human volunteers and transplanted recipients, most by using immunoassays to measure tacrolimus in plasma or blood. However, because of the cross-reactivity for certain tacrolimus metabolites of antibodies used, these modalities often lack specificity. This should be carefully taken into account when interpreting pharmacokinetic results for tacrolimus. In adult recipients, tacrolimus is generally rapidly absorbed following oral administration, and the time to reach maximum concentration is in around 1 to 2 hours. But in some recipients, absorption is slow or even delayed because of the systemic elimination. The bioavailability is low, but may vary between around 4% and 89%. Tacrolimus is highly bound to erythrocytes. Its binding to plasma proteins varies between 72% and 98%, depending on the methodology used. Because of the extensive partitioning of tacrolimus into erythrocytes, its apparent volume of distribution based on blood concentration is much lower. Much lower compared to values based on plasma concentrations. Tacrolimus again is metabolized by cytochrome P450 or 3A4 to at least 10 metabolites, some of which retain significant activity. Biliary excretion is the route of elimination of the tacrolimus metabolites. Systemic plasma clearance of tacrolimus is very high, whereas blood clearance is much lower. The terminal elimination half-life the terminal elimination half-life of tacrolimus is approximately 12 hours. Limited information had been available on the pharmacokinetics of tacrolimus or FK506 in pediatric recipients. And again to stress again, but in the to stress again before the mid 90s before the sort of mid 80s and mid 90s, the only limited information is or was available on the pharmacokinetics of tacrolimus in pediatric recipients. The rate of extent of tacrolimus absorption after oral administration do not seem to be altered in pediatric recipients. The volume of distribution the volume of distribution of tacrolimus um, based on blood concentration in pediatric recipients is approximately twice the adult value. Blood clearance of tacrolimus is also approximately twice as high in pediatric recipients compared with adult recipients. Consequently, the half-life of tacrolimus does not appear modified in children or pediatrics, but oral doses need to be generally twofold higher than corresponding adult doses to reach similar tacrolimus blood concentrations. More pharmacokinetic studies in pediatric recipients are, however, required to rationalize the use of TDM for optimization of tacrolimus therapy in this patient population. There are a number of biochemical investigations that bring methodological problems associated with the measurement of CSA, cyclosporin, and FK506 or tacrolimus, which had influenced the interpretation of the results. These difficulties have been reviewed in many medical texts and journals that relate principally to the choice of sample matrix and the selectivity of the analytical technique. Data from the UK cyclosporin or CSA quality assessment scheme, which included over 170 centres throughout the world, has showed that 5 principal modalities for measurement of immunosuppression therapy have been in use. They've included a HPLC, high performance liquid chromatography, two specific radio immunoassays or RIAs, based on monoclonal antibody produced by for example Sandoz pharmaceuticals retrospectively are used, and then a high specificity fluorescence polarization immunoassay, which retrospectively have been developed by Abbott Laboratories in the United States, using another monoclonal antibody produced by Sandoz as well, and a non-specific fluorescence polarization immunoassay based on a polyclonal antibody produced by Abbott Laboratories. Historically, laboratories at the same time are using sort of a non-specific radioimmunoassay based on monoclonal antibody that had been made by Sandoz, but the trend is towards a specific measurement of a parent compound. Two other specific immunoassays have been developed, and they are an enzyme multiplied immunoassay or EMIT assay produced by Siva Co. And an affinity column mediated immunometric assay produced by the DuPont Co. in originally based in Wilmington, in the United States. The introduction into routine laboratory had been imminent retrospectively. The analytical techniques available do not produce the same numerical value in each case. There is a difference of the results produced by HPLC, for example, high performance liquid chromatography, and those obtained by specific immunoassays for samples from recipients treated with CSA and FK506. The mean results for pooled patient samples or pooled recipient samples are lowest for HPLC, whilst the specific immunoassays give higher results. CSA and FK506 are structurally unrelated, but have a very similar nephrotoxic effects. The intracellular binding proteins for FK506 and CSA are different. However, immunosuppression effect is similar. Primary immunosuppression of T cell responses. Both CSA and FK506 decrease GFR and urinary excretion of nitric oxide, Nitric oxide is known to be a potent vasodilator as well. It is well known that CSA induces endothelium synthesis, which is a potent vasoconstrictor. Thus, vasoconstriction is probably an important pathogenic factor in nephrotoxicity. Both drugs appear to have a direct a tubulotoxic effect, and they are most likely inhibitory to tubular epithelial cell regeneration. In acute nephrotoxicity, in the post transplant sort of phase, acute renal failure may occur or the normal post transplant decrease in may occur or the normal post transplant decrease in serum creatinine has an abnormally slow pace. In chronic nephrotoxicity, a gradual increase in serum creatinine concentration is noted. Chronic nephrotoxicity usually occurs several months post transplantation. Professionals, i.e., clinicians and laboratory specialists, understand and are aware of sort of the methodological problems, which is why they continue to monitor the biomarker creatinine and plasma and blood concentrations for nephrotoxicity. Um, for nephrotoxicity and overall sort of and overall efficacy for the use of for example immunosuppression, CSA or tacrolimus. Laboratory specialists use varying equipment or apparatus which interprets data interprets data differently. Thus, no accurate established regimen is fixed to say there is a set dose for pediatric renal sufferers, and the same applies for adults. Uh, animal investigations in Wistar rats and pigs had demonstrated that unlike treatment with calcineurin inhibitors, sirolimus or SRL treatment alters neither renal blood flow nor glomerular filtration rate. The absence of nephrotoxicity had been confirmed in humans at the end of the 12-week treatment with sirolimus at three different doses. Psoriasis patients exhibited normal renal function, as did a control cohort of recipients given a placebo, given a placebo only. In addition, the results of phase 2 randomized trials involving renal recipients in which sirolimus and CSA were compared as base immunosuppressive therapy showed or highlighted that 2 years post transplantation serum creatinine levels were always lower in sirolimus treated recipients. The results also showed that unlike calcineurin inhibitors, sirolimus does not induce nephrotoxicity. Because sirolimus has potent it has a potent immunosuppressive profile and does not cause intrinsic nephrotoxicity, it had also been used as a base immunosuppressant therapy together with steroids and either azathioprine or mycophenolate. Two prospective phase 2 randomized European studies using therapeutic dose TDM or therapeutic dose monitoring centered on the comparative effects of combining either CSA or SRL with steroids and AZA, or with steroids and MMF. In one investigation, the incidence of acute rejection or AAR, acute allograft rejection episodes in the SRL and CSA groups were comparable, 41% versus 38%. In the other recipients were given sirolimus SRL, steroids and MMF had slightly but not significantly more acute rejection episodes than those given CSA, steroids and MMF, 27.5% versus 18.5%. Note that in both investigations, renal function at 1 year was significantly better in the SRL than in the CSA cohort. The results suggest that in the triple drug immunosuppressive regimen, sirolimus or SRL had almost the same efficacy as CSA, and that in contrast to CSA, it is unlikely to cause chronic nephrotoxicity. They also imply Investigations also imply that SRL is a non-nephrotoxic agent capable of competing with a CSA for the prophylaxis and precluding AAR in renal transplanted recipients. However, it should not be combined with CSA for more than 2 to 3 months. The situation with regard to CSA is in some ways different. In one investigation, a meta-analysis on CSA withdrawal was performed on 13 studies or on 13 investigations. The remaining immunosuppression was azathioprine and steroids. The 10 studies that examined the effects of CSA withdrawal on acute rejection included 1,049 recipients with 50.7 plus or minus 33.9 months follow-up. The 12 studies that provided adequate data on graft survival prognosis after CSA withdrawal included 1,151 recipients with 45.1 plus or minus 32.9 months follow-up. For acute rejection, the pooled mean difference between CSA withdrawal and control was 0.11, indicating that the proportion of recipients with acute rejection or rejection with a rejection after CSA withdrawal was 11% than for sort of placebo or controls. Than for the control cohort. The relative risk for graft failure was 1.06, indicating no significant difference in the risk of allograft failure in the CSA withdrawal cohort compared with the controls. In summary, although there is a slightly higher risk of allograft failure allograft failure for acute high risk of graft failure and acute rejection episodes following conversion, no long-term risk for allograft rejection have been observed. Successful withdrawal of CSA lowers ABP, improves allograft function, and may affect mortality more positively. There is a well-known risk for short-term and long-term nephrotoxicity of immunosuppressive drugs, in particular like calcineurin inhibitors. Structural toxicity cannot be diagnosed easily by non-invasive means. Monitoring parameters other than creatinine, such as urinary enzyme excretion or urinary cytology, has not proven to be diagnostic in this regard. Even for pathologists, the differential diagnosis is not easy for chronic allograft nephropathy, for example. The contribution of toxicity had been shown indirectly by conversion to calcineurin inhibitor-free immunosuppressive or immunosuppression therapeutics. Although the additional effect of improved immunosuppression on chronic renal failure or rejection cannot be or was not or has not been determined. The metabolic consequences of long-term immunosuppression have now been discussed. Suffice to also say, when sirolimus was introduced, there was great hope to obtain adequate immunosuppression without nephrotoxic side effects. In previous studies or investigation, hyperphosphatemia, metabolic alkalosis, and low uric acid were reported as a possible consequence of tubular damage under SRL. In a trial comparing sirolimus, SRL, and CSA, the study analyzed markers also of tubular dysfunction to investigate nephrotoxic effects of SRL, transplantation immunosuppression therapy, and markers of tubular proteinuria and alpha, for example, in around alpha 1 microglobulin and retinal binding protein have been in more sort of retrospective investigation have been pivotal and were significantly where data highlighted significantly elevated where data had highlighted that markers of tubular proteinuria, alpha 1 microglobulin, and retinal binding protein were elevated from day 14 in recipients under therapy with SRL. This elevation remained constant throughout the observational period. Uric acid and bicarbonate as markers of proximal tubular reabsorption are significantly decreased on day 14 and 30 retrospectively. So that now draws this audio podcast to a close. This audio podcast is part of the Erythropoiesis edition. This audio podcast is part of the Heraclean Plexar. This audio podcast as part of the Labonix Vendip. This audio podcast as part of A Storm Labonix production. Thank you.